turn myself on. And I've been told I can't stand in front of the screens because they're videoing this, and he said it made me bloom. There's a big white flash. First of all, I'd like to thank Ward and the Quality Council for asking me to come back. It's a privilege to be here. In preparing this talk, I realized that I hadn't been in Calgary for 4 or 5 years, really, except for social visits, and also that it made me reflect on the fact that this is one of the places where Canadian patient safety was born. And I'll tell you about that in the talk. So Ward suggested that I needed a title, and then of course I wasn't allowed to make up the title. Ward suggested the title, and then I said, well, Ward, is that really the right title? And Ward said, yes, that's the right title. So the title is Patient Safety, Past, Present, and Future. Well, when I thought about how this should start, we should start in the past. Oh, by the way, I have to declare all this stuff. I don't work for drug companies. I don't work for big pharma. I don't work for the university anymore. I don't work for anybody but me. So I thought you should start with Hippocrates. And it was where I met Ward today, right by Hippocrates downstairs. He said this is one of the many ways this has been translated from Greek into English. Make a habit of 2 things, to help and at least do no harm. Now, you can think, it's interesting to think why he would have said that, because think what medicine was like there. Some people have described it as medicine was contemplation. You'd come up to your sick patient and you'd say, one of 2 things, you're going to live, or 3 things. You're going to die, or I don't know what's going on. But you usually couldn't do much. You might put a leech on them or something, but probably never did very much harm. Fast forward to the First World War. We could all of a sudden do a lot of stuff. They were cutting gangrenous limbs off, and we had the first antibiotics really come in the Second World War. You had the ability to change the course of illness, really change it, but with that came the risk of changing it and the human fallibility about air. I thought before I left Hippocrates, and so he said this, and it was right then, and it still is right, but it's harder for us to do it in modern medicine. That's what I'm trying to say. But he said some other interesting things, and I thought I'd just show you a couple. Cure sometimes, treat often, but comfort always. That's coming back into modern medicine right now. Comfort is becoming more important, especially in the aging people, than curing, as we look at chronic disease initiatives and stuff. So think about that. This guy, 2,000 years ago was telling us that. And look at this one. Walking is man's best medicine. How many of you have got one of those things that tells you how many steps you do a day? See? This one reports it to my phone. And then I get graphs. And it gives me so many stars a day as I try to get my 10,000. All right. Well, that was interesting, a little bit of history, but let me quickly say how we got here. There was a study published in the New England Journal. It should have been important, right? 1991, called the Harvard Medical Practice Study. This is really a foundational study. They looked at, it was population-based in New York City, looking for iatrogenic injury. They looked at a huge number of charts, and they concluded 4% of hospitalized patients in New York in the year 1984 had an injury that prolonged their hospital stay or resulted in measurable disability. And when they projected out how many of these people died because of that to the American population, they said almost 200,000 people died a year because of things that shouldn't have happened. 3 jumbo jets crashing every 2 days. So this was very interesting. It got New England Journal. It should have moved the world, right? Not a sound. Nothing. Except Australia, where a guy called Ross Wilson, very interesting guy, picked it up, got some money, and redid the study in Australia using the techniques. He sharpened the definition of an adverse event. They looked at 14,000 admissions using a standard methodology, which is a double chart review, and they concluded 16% of patients had an adverse event, and half of them were preventable. About 5% of patients died because of this. And they added 7.1 additional bed days per patient. That's a big dollar number, right? You'd think that would get a lot of attention. Well, there was a big turmoil in Australia because the Minister of Health released the paper before it was peer-reviewed. And there was a big fight between the universities and the ministry. But did it change things? You couldn't even get a copy of the paper at the University of Toronto because the journal didn't come there. I had to get it sent from Australia. But I saw this reported in the literature, and I said, I talked to Ross, said, this is really important. This might be, we were trying to get quality improvement. This might be the lever. If we get a number like this in Canada that's defensible, this might be the lever to change the way we think about practice, to say there's an opportunity to improve practice that must be taken up. So we began lobbying. I talked to a Minister of Health, Canadian Minister of Health, a short person that liked to stand on little, I won't say his name. Dr. Norton, we do not need to do this study in Canada. Canadian system is better than the Australian or the American system. True quote. However, there was a person, John Miller, and I have to credit John. He was vice president at CI, and John listened to us and said, I think this study should be done in Canada. We said, we need to do this study. And he said, well, write me a little proposal. So I wrote him a little 3-page proposal. And the bottom line figure was $800,000, and he goes sort of gulp. We can't afford that at CI. They didn't have that much money. So he went and formed an alliance with what was just starting from MRC changing to Canadian Institutes of Health Research. And they agreed to put some money in, and they got a pot of $1 million together, and they put a call out, and we applied, and we got the grant. So that was really nice. While this was all happening, I forgot I'd put this in because Ward talked about it. This came out, and this was stirring things up. This report is, if you've never read it, you must read it if you're going to do quality and safety. And if you haven't read it, if you have read it, it should be on your bookshelf. It's got all kinds of gems in it. And it was enough to get some popular interest. Here's a cartoon that came out the same year showing that the public was now reacting. The report says medical errors such as indecipherable prescriptions caused the death of 98 patients, or is that 900 or 98,000 patients per year? It's hard to read this. In any case, we're supposed to report them, or is that repeat them? And so you see, the reason I put the cartoon up, it's sort of cute, but it says we're attacking, we got the message out to the public. That already influences politicians. And this was influencing Canadian politicians, and I think that's why John Miller was able to push this thing through. We started this project in 2002, and we published it in May 2004. That's a very fast track for a big health services research. Everybody helped. CMAJ got a special panel of international experts ready for review when we got the manuscript ready. And it went through review in 6 weeks. Review and editing. So a lot of people got together because we wanted this number. Now, what were we trying to do with this? Were we really, first of all, let me tell you what an adverse event is, just in case. We used Ross Wilson's work. He thought about, now you've all got this down pat, right? Let me just do it anyway. An unintended injury or complication which results in disability, death, or prolonged stay and is caused by healthcare management. Okay? It's not the same as what an error is. An error is when you do the wrong thing or you leave a step out or something. To make it very clear, here's adverse events and errors. There is an intersection, but you don't have to have an error to have an adverse event, and you don't have to have an adverse event to have an error. Here's a patient who has no history of penicillin allergy. Penicillin's ordered, given to the patient. Patient has anaphylactic reaction. That's an adverse event. But there's no error there. It was just the way the world turned. This one down here, you've probably done all this with them more, but I'm going to do it again. Penicillin was given at a dose of 500 milligrams when 250 was ordered. Patient progressed as normal, got better. That's an error. There's no adverse event because there's no consequence. Chart indicated a penicillin allergy. Penicillin is ordered by mistake and given, and the patient gets a severe reaction. That is both an error and an adverse event. So in the case, and here's the interpretation by the cartoonist, but you have to admit the new drug did shrink your prostate, Mr. Eilers. So the Canadian Adverse Event Study, study the blue circle. The next thing I want to say about the study was not trying to find how many things were in there. It was trying to get a defensible lower bound, a lower bound that could not be challenged. Even by Ward, who told me the lower bound was too high the first day he saw the study. He did. He said, I don't have that kind of adverse event rate. Everybody was like that. Everybody said, we can't have that many because you don't see them when you're working. You don't see them as a conglomerate. We found that the overall adverse event rate, this is a lower bound, was 7.5%. This means 1 in 13, these were only adult hospitals we studied, adult hospitalized patient in the year 2000 had an adverse event. So in a ward of 40 patients, over a year, count up how many, and the average 5-day stay, this is a big number on the ward, right? Is that number correct? No, it's a defensible lower bound. It cannot be challenged. I'll come back to what the right number is, if we know. 2.8% of patients had one or more preventable, so our preventable rate was around 40%, a little lower than Wilson's. We stratified the samples, so we looked at big teaching hospitals, large community hospitals, and small community hospitals. And it was important because we deliver a lot of our care in small hospitals in Canada, a lot because of our geography. So this is an important thing we did, and the preventable adverse event rates were the same across the 3 hospitals. And the acute care, the teaching hospitals all said, well, they dumped their adverse events on us. Not true. We had to deal with that. We estimated 1.6% of people hospitalized in Canada had an adverse event and died. You can see the confidence interval does not go across 0. And that worked out to 16,000 deaths a year in Canada. Well, this caused a little stir when it came out. But let me go back to the defensible lower bound. The statistics and all the assumptions made in the study, you're always making assumptions, like we will throw these kind of charts out and stuff. They all, if we hadn't, were made in the direction to get a lower number that's correct. The right number, as far as we would guess today, is about 4 times that. And probably the gold standard for actually trying to get the right number is observation by independent people on a ward. That's how you probably find it. That gives us the highest numbers. Do we ever need to do this study again? No, this study was done for political reasons. It was done to change the culture. And I get asked quite often, I think less now, people are sort of starting to get it. This is not, if we did it again and got a different number, we couldn't interpret it as change in the system because of that huge gap. I was, as Ward pointed out, luckily allowed to be part of founding the Health Quality Council of Alberta and was a board member for a long period at the beginning. And one of the things we did, I might have been because I was on the board, was do population-based surveys to ask the public, what did they think was going on with adverse events? Are people being harmed? And these were population-based and well done. And look at their numbers. Whoops. Look at their numbers. It was done in 2003, 4, and 6, and it has a rate of about 15%. Now, why is that not where I said it's at 25? Because a lot of times people don't know that there was an adverse event. So these are important studies verifying this number from other perspectives. What happened in Canada after we published this? There was a lot of stuff went on. The federal government founded the Canadian Patient Safety Institute, which still exists and has been an important vehicle for us. Accreditation Canada got wind of it. Well, I went and talked to them, and they started putting in what are called required organizational practices. They're all over the place now, saying you've got to do things directly related to what we know about safety and quality. ISMP, the Institute for Safe Medical Practice Canada, really cranked up its work, and some of you that work on wards will see them send out bulletins about things. And it really engaged the pharmacists in this work with us. We founded health quality and safety councils in almost every province. Patient safety measurement got the attention of the business community, and they started making programs and stuff to help us try to count adverse events. And of course, as Ward said, we founded Safer Healthcare Now. Now, what was the motivation for doing Safer Healthcare Now? First, we sort of got through I did 48 media interviews in 6 months and Ross did a few more than I did. You get pretty tired of doing that, but there was a lot of interest after the study came out. But we sat back and we said, well, this is very interesting, but we haven't really done anything. It isn't enough to give people just the number. That doesn't change the world. You can't change the world if you don't know what you're doing, if you're not measuring it. But you can't just assume the number. And the Americans were doing the 100,000 Life campaign, and we said, we're going to do this in Canada. Well, I got to tell the whole story. So I went down and talked to Don Berwick and the guys and with Ross, and they'd be happy to help us do it here. I came back, and Jack Davis was the CEO at the time. I said, Jack, I want to tell you we're going to do this 100,000 Life kind of thing, these collaboratives to get safety better in the Calgary region. Jack said, no, you're going to do it in all of Canada. He just said it like that. And so that pushed us to found this thing. We launched it in 2005. There were many, I can't name all the people that were involved here. There's a raft of people, and a lot of those people are in senior positions in various places now. Some as senior as me, Emeritus, that means you can retire. No question, it's the largest quality improvement initiative ever undertaken in Canada. It was based on the Institute of Health's in the States 100,000 Life campaign. We started with 6 initiatives, 3 in intensive care and 3 in acute care. They're up to 15 in 2009, so it's in a bit of transition at the moment. And what it did, it focused on bundles, what are called bundles of care. You'd say, take a condition like heart attacks, and you say, what is all the known best evidence to get the best results in heart attacks? And that was a bundle. And then and here's some bundles. Here's the acute myocardial infarction, had 5 things in it, 6 things in it. These were all evidence-based processes that should be improved, that we knew there were some gaps in, we thought, and the outcome measure was 30 days AMI mortality, but the work was going to be to improve the processes to get an improvement in the outcome. Here's the surgical site infection, and well, the ones that are in blue are the ones I'm going to show you the data on. Timely antibiotic prophylaxis prior to the first cut. You're supposed to have some antibiotics on board most of the time. And appropriate hair removal. That means you don't shave, you clip. Because shaving opens up the skin and the bugs crawl in. And there's a discontinuation of the antibiotics, and the outcome measures 30-day mortality. And med reconciliation, which we did with the pharmacists, undocumented intentional discrepancies. That means you consciously at a time of transition change the patient's medication, but you don't write down why. And then when the next person looks, they can't figure out what the heck's going on. That's like a latent error, what James Reason calls a latent error. And unintentional discrepancies where you just write down the wrong drug. And this would be the rate of ADEs. I put the outcome measures in because one of the disappointing things in Safer Healthcare Now is we can't see after this Now, 10 years of work at a national level, any effect on these outcome measures that we can attribute to safer healthcare now. I'm going to show you we can do it at an individual unit level, but it hasn't spread. Hasn't, as we like to say now, scaled up. We haven't changed the system yet. Now, because I was there, as Ward said, there was a big initiative. We were launching it, and so there's going to be measurement. So let's just talk about what the initiative was. We picked the areas, we got them from the Americans, and we fine-tuned them. In fact, the MedRec one is Canadian. The Americans were measuring it wrong. They hadn't even got a good measure, and they've used ours now. So it was a good interaction between us and the Americans. We trained them using standard QI methods, particularly the Plan, Do, Study, Act cycle, which I'm sure you've seen sometime in this course. There was ongoing coaching and facilitations. Teams volunteered to come in. They were given coaching by quality and clinical experts. Measurement tools were developed. They were online, and they allowed you to measure processes. How many of our patients came in, they take a convenience sample, and how many got aspirin within 30 minutes. And bang, the thing would send you back a graph. It's a pretty neat program, and we were trying to get the teams to, this was all voluntary, so you couldn't make them, give us monthly measurement. Now this thing was a huge success. If you say, did we sign up teams? Just look at that. That's the growth of teams. We started back here, 118 teams. Up here in September, 1,107 active teams across the country. That's a huge growth. But you have to ask the question, did it make a difference? And is it enough just to say people are signing up? Well, let me say that I think that it produced a visibility factor that shouldn't be underrated. People know about it, talked about it, started doing things about it. So that was very, and people started thinking about effective safety practices. But is there any evidence of impact, or is it just enrollment? Are effective practices, are there effective ways to make these teams work more efficient? Because it was quite expensive. And finally, what have we learned about accelerating and scaling up improvement? Well, I'll start at the bottom. Nothing. Really, we don't know how to do it yet. And for the second question, not very much. However, for the first question, I'll make an attempt to say something. This is data that is only on internal reports to CPSI. We've tried to get it published. It's too complex, and we got tired. Let me show you how much measurement we had. This is the course of Safer Healthcare now up to 2015. The red line are what are called the new initiatives, and the blue line are called the old initiatives. That's not important. What I'm showing you is the growth. You have to add the red and the green line together. How many reports we have in the data bank from teams about how they were doing with processes. It's a big data set. 36,000 K records. Well, we should be able to find something out of that, right? Here is a typical look at the records. This is SSI1, which is timely antibiotic prophylaxis. Okay? Time. And on this axis over here, the one on the left, is the percentage of teams that send us a report. 1 report, 2 reports, 3 reports, 4 reports, up to 45, 46 reports in 48 months. Okay? Of the teams that sent in 13 reports, the blue line shows you what their average rate at the 13th report was. So this is what happened at the beginning. All the teams that entered and gave us a report said that they were hitting the target. They were doing this 65% of the time, average across Canada. The longer you go on, up to at least 2 years, the higher that line goes. Then it seems to just taper off, except right at the end, these 4 or 5 teams finally got across the red line, which was the goal. Now that's pretty hard data to analyze. Are the teams that report 15 times different than the teams that report 7 times? What's the right group to look at? So we set out to say what was a good study cohort to try to understand what was really happening. And we said, we'll take all the teams enrolled in just these 3 that reported at least once to the central management team, sent in 1 report between 2005 and 2009. And we said each of the reports are different. These people might report every 3rd month. These ones might report every month. But the reports together formed a story for that team, what they had done during the initiative. And we wanted to look at those stories. We developed exclusion criteria. We said if you didn't report your first data till after 2008, you weren't going to be in long enough for us to see anything. So let's take them out. If you only reported 3 times, well, it's trying to look at a line with 3 points on. Do you know what's going on? Throw them out. And if you reported less than 4 times a year, I couldn't be convinced you were actually working at it. You know, so I took them out. What did that do to the, and this is the numbers we ended up in these 4 initiatives. AMI won the aspirin at arrival, 60 teams, and so on. And in particular, if you take prophylactic antibiotics, 285, if you remember from the graph, reported once, but when you put this criteria on, you only get 2/3 of them. That I think there's a good story in the data set. Doesn't mean the others didn't do a good job. This is the only ones I could study. And that 2/3 is sort of consistent across all of these. Everybody clear on that cohort? Now, you take each of these stories, right? It's got a few points in it, 10, 14, 17, 21. This is in January. This is in, the first one here is in March. So we said, let's take each of these stories and divide it into 4 pieces. Your beginning, about a quarter way through your story, a third of the way through your story, 2/3 of the way through your story, and the end. That's how we decided to study it. You see why it doesn't get into journals easily. So you had, for each story, there were 4 observations. The beginning, a third of the way, 2/3 of the way, and all the way, 01, 02, 03, and 04. Okay. So here's all the 01s averaged, all the 02s averaged, all the 03s, and all the 04s. And this is aspirin at arrival, and better means more. Higher percentage of people got it. And this eliminates the ones that aren't able to take aspirin because they're bleeding from an ulcer. And look at the confidence intervals, and you can see there's no improvement. Why is there no improvement? It started out too high. There isn't enough of a gap there. One of the things when you're going to move something is make sure there's a gap, there's evidence you can close the gap, and there's will to change the gap. And this was just, the Americans gave us this. We didn't ask that question. It shouldn't have been in there because there was a wasted effort. However, here's smoking cessation. So this one said, if you had a smoker who had an MI, they should get counseling, at least 1 counseling session before they leave. There's rock hard evidence that keeps less people going back to smoking. It saves lives. Well, the team started at the beginning at 43%. Within a third of the way through their story, they pushed that up to 70. And you can see the confidence intervals don't overlap. That's a big, real change. And they got a little bit more gain as time went on. 2 lessons from here. A lot of the gain, once you really get started, is made early. Doesn't mean you shouldn't go on, because that's sustainability. And we, just because I have to say these things, we used Wilks Lambda. Any of you that haven't yet experienced Wilks Lambda can go and read about it. But it says that that's a real change. And here's for the 4 things I told you about: aspirin at arrival, smoking cessation, intentional and unintentional medical discrepancies, and antibiotic prophylaxis and hair removal. All of them are significantly changed, except the one I told you why. With safer healthcare now, and if Well, for those teams that did something, and if you go out now and try to figure out, is there more smoking counseling? The answer is you can't get any evidence. Are more patients actually getting prophylactic antibiotics in all of Canada? There is no evidence. That one might be moved. So that's where Canada was sort of 2009. What is happening in the rest of the world? How much time? I got a few more minutes. This is a very important article. This is by Pronovost and his colleagues in Internal Medicine, Annals of Internal Medicine in 2013. It's like sort of like a meta review kind of thing. They went to the literature and they said, what do we know should be done because strongly encouraged means there's Class A evidence that doing this makes more safety. Encouraged means, well, we aren't quite sure. The evidence is a bit wishy-washy, maybe what you'd say B in a meta-analysis. But let's at least think about it. That's a big list, right? Big list. Lots of things we could do. Some of them we're working on. Hand hygiene is having a very rocky course across Canada right now. For example, any of you that are working on it know it's non-trivial, right? Sounds easy, just make everybody wash their hands. But you've got doctors, and they're very, very hard to control. I'm going to tell you just what the literature says about a couple of these, because I think they're informative stories about where we might go in the future about improvement. And the first one I want to look at is checklists. So you know checklists are pretty important in aviation, right? The pilot and the co-pilot do checklists. And they walk around the airplane, and there's things they have to do before they take off. What they essentially do is say, is the airplane ready to take off? And they check things like, is the weather maps all in place and everything? Are we ready to go? They have an actual discussion about being ready to go. And are there any things we need to do before we go? Sounds like a good plan. And it works. We've got great aviation safety. Just let me take a little side thing. Harm in surgery. Surgery is an essential component, but in all the studies, not just ours, surgery is the most dangerous thing to have happen to you. Well, all the ones we can measure. You know, I wonder about chemotherapy, but we can't seem to find any good data. You wonder about radiotherapy, and we have sentinel cases that look horrible, but and other things like that. But surgery is a place to work because there's an opportunity. The gap is there. The gap is there. So this became a rallying cry. We're going to do checklists in surgery. And what you do is the team sits down before the surgery and they go through a set of things. We've got the right kits up here. You know, they come in bundles, and they've got to have the right kind of a prod in each bundle. And have we got the antibiotics here? And is this patient's antibiotics started? And are we sure that the anesthesia check was done properly? And is it here? And so on and so forth. Simple little checklist takes about, 7 minutes max. And most times it takes about 3, but occasionally you have to stop and talk. Gawande, who's been he's a brilliant scholar in the States, has written New York Times bestseller saying this has to happen and gives evidence that it should happen. Okay, well, let's look at the New England Journal. They always report the best things. I already showed you how they shook the world for 2014. This is read the title, Surgical Safety Checklist to Reduce Morbidity and Mortality in a Global Population. They took, if you read down in here, you can see it, 8 hospitals in one hospital in each of 8 regions. And they put surgical checklists in, and they wanted to see if things got better. And they said mortality went down by half, and mortality associated with surgery. And inpatient complications went down by 1/3. That looks pretty good. Doesn't that look good? You're all going to go and do checklists now. Well, remember, this is a very artificial situation. Do you know how many research associates and stuff? And what about these 8 hospitals that volunteered? Are they typical hospitals, do you think? I think they went out and harvested people that could do the job. because at the same time, Ontario was introducing it. And in the same year, in the same journal, we have introduction of surgical checklists in Ontario across the province. They studied all of the patients. They used the ISIS databases to see were things actually getting better. 101, 3 months before and 3 months after, they can do big things. This is what it looks like. Those are the 102 hospitals and the confidence intervals and stuff. Adjusted risk of surgical complication didn't change. Only complication significantly, with a significant change was return to the OR, which changed by a very small %, but it was significant. And DVTs went up. It's a before-after study. It's not a causation study. But it didn't work out like the other articles. So how, at the end of the day, what do you put these two things together and understand? Well, this is a real study, in a sense, but it's got all the complications of a real study that you don't know what's really going on. You're just looking at the data. The other one's a very controlled study, which you can't take out into the field. With Lucian Leap, did you ever talk about Lucian in this course? Lucian is a mesmerizing, brilliant grandfather of safety. Was asked to review these. The likely reason for failure of the surgical checklist in Ontario was that it wasn't used. That's what he read in the data. So it isn't as simple as doing a big randomized trial or a big trial and getting the right answer. Well, that's interesting. Let's look at the next one coming down. These are preventing central line infections. This is a bad thing, right? You put a central line in someone, into their artery, and if it gets infected, you get infection in the heart, you get emboli, toxic emboli to the brain sometimes. It's bad, bad. People die. Even if you live through it, you're going to have a very long recovery. This is what the evidence says you're supposed to do to get better. You wash your hands. You don't start putting this line in unless you've got clean hands on. Everybody washes their hands. The nurse, everybody. You have full barrier precautions. You don't just walk in and put a pair of gloves on and shove the line in, which you can see happen, I bet you, in the ICUs here today. You all gown and mask. You clean the skin with chlorhexidine. Sounds pretty simple. It's cheap. It costs very little more than water. You don't use the femoral site. You put your risk way up. And you remove catheters as soon as they're not necessary. Don't leave them in. The longer they're in, the more likely the bugs are to crawl down, right? Pretty simple set of things. Well, here's back in the New England Journal. They seem to publish this stuff. This is the results of an effort by Pronovo in Michigan. He went around, he's a champion, and he's a leader, and people respect him, and he had enthusiasm and energy, and he went around and enrolled almost all the ICUs in Michigan and said, we're going to do this routinely on every central line. And they did it, and of the 103 that actually sent data in, he had, even in this study, which had huge funding from the NIH, he didn't get all of them in, but he reduced the rate of infection from 2.7 to 0, essentially, statistically 0, 3 months after implementation. This caused a big stir. Everybody liked this paper. What accounted for the Keystone? Well, this guy, Dixon Brooks, said, why did they do so well? He went and studied it. The checklist, they were using a checklist, he said was necessary but not sufficient. You couldn't just use the checklist, back to the other one. And the things that seemed to make this work were competitive pressure. You've got the data of the site down the road, and they were doing better than you, so you worked harder. sharing of information. They were using a collaborative model, so everybody talked about problems and barriers. Better data on infection rates that you could actually attribute, that make the team believe that the infection rate was due to the poor the insertion. And use of persuasion, what he calls soft techniques, and sanctions, hard techniques. So some of the sites, the CEO of the hospital said, if we don't get under 4 next month, I'm going to do some major changes here. Things like that actually happen. Well, the story isn't finished yet, because there was a project called Matching Michigan. Because everybody liked this and wanted it. I mean, this is huge, because these are really bad. One is a bad thing. And so they went to England, and England said, we're going to match Michigan. And 215 out of 223 in England signed up. Now, there was a little bit of soft persuasion and quite a lot of hard persuasion in getting them signed up. And over 20 months, they took the rate down from 3.7 to 1.48. And even more importantly, in the pediatric ones, they went down even more as a percentage. These are really important in terms of quality and safety initiatives. So our friend, the one who studied the Michigan, studied this too. And he said, this is what made you successful. Because it wasn't everybody went down. That's the average rate. Some people went up, some people went down, some people stayed the same. Average went down. Previous efforts to improve infection rates perceived as punitive, and if they'd been in there being punitive before, you didn't engage very well. Individual ICU experiences and histories, including local leaders. Listen to these, local leaders. Availability and use of data. The data was coming to the clinicians who were actually putting the lines in a form that they could understand, and past experience with quality improvement. Those were the critical things that made a real success ICU. And I won't read this particularly, but what he's saying is essentially this is a long quote out of his article in 2013, if you want to read about it. He looked at these things and he's had some deep thoughts about what you need to make this work. Dixon Woods, 2013. But essentially, it's what I summarized on the previous slide. Or here, interventions depend on implementation and context. That's what they're saying, the context you're working in. So if we're going to get effective implementation, we need strong clinical leadership at the microsystem. That's a technical word for unit level. Effective teamwork and communication skills. Communication comes out in this. If you're not talking well in your team, you don't make it. Local accountability for local data and accountability performance. It does no good to feed back the high data. They don't believe it. You've got to collect your data locally. You've got to own it. Quality improvement capability. People have had to have previous experience. You've got to give them the tools to do quality improvement. It's a science, just like medicine or nursing. It's a science, or pharmacy even. I'm trying to find the pharmacists. Quality improvement capability, ongoing learning and reflection about performance. You need to facilitate people to continue learning and thinking and reflecting on what they're doing, and support from senior leadership. A lot of people put that at the top, but I think it's in its right place in this list. Well, I've only got 7 minutes to tell you. Have I got too much time? Can I do this part? This is what I wanted to tell you what I've been doing since I sort of took you up to 2007. We're fooling around with Safer Healthcare Now data. I'm retiring, and I got. I ran into a person called Carol Esterbrooks, who holds a Tier 1 chair in knowledge translation up at Edmonton. I was still down here, and it became clear to us very quickly that we had a commonality, that patient safety, quality improvement, and knowledge translation all have the same goal. Make sure we do the best job at the bedside, or in the system, or something. And all have brought different tools and views together, and we thought if we brought that into a togetherness, we would be able to do something. We decided, for technical reasons, which I'll outline briefly, that we were going to study nursing homes. Why? Constrained system, like it's not as messy as acute care, has much more uniform, like in Western Canada, they're all on flat payment. So there's not a lot of things about, like we do transplant surgery, so we get an extra $27 gazillion, which we can distribute in the system, or stuff like that. There's a lot of stuff that make it hard to study the acute care sector. And it hadn't had a lot of attention, and it's clearly a place where no matter what you think about aging in place, it's going to increase in its importance because dementia is increasing so fast and at the end stages of dementia. The role of nursing homes is changing. They're becoming end-of-life care for demented patients. But that doesn't mean they don't need improvement if there's gaps. So we decided to do that. I'm a senior scientist, co-founder with Carol. We started in 2007. We now have 30 researchers from around the world. We've got almost everybody interested in this in Canada in this team at a health services level. 15 decision makers, senior decision makers in the West, 7 grad students at the moment, comes and goes. You can see about it by going to Trek, University of Alberta. What Trek is doing is focusing on this. Practical solutions that contribute to sustainable improvements in the quality of care, quality of life, and quality of end of life for the frail elderly in nursing homes, and the quality of work life for their caregivers. Work life in a nursing home is hard. They normalize being hit, bitten, and peed upon, and spat on, and sworn at. That has to become normalized. Most of us wouldn't go there. And we based this on something called the parish model. This is the parish model. It's not a theory. It's not that far along. It was developed by Keystone and her colleagues in the United Kingdom, and it stands for promoting action on research implementation in health services. And it proposes that if you look at the 3 components that are necessary, the evidence, the context, and I'll come back to that, and facilitation, and if they're working together, you get better practice. What is evidence? Evidence is robust and accessible. You can understand the evidence. It's like the list I showed you from Pronovo et al. There's evidence there. These are things we should do. Facilitation is what we've already talked about. It's about helping people make the change, making sure they've got models and science about improvement. You can't just leave them alone. You have to help them. And finally, context. They called context the culture, the leadership, and evaluation practices in your facility. Evaluation meaning get data and act on it through improvement techniques. You can think of context as the organizational, the environmental organizational environment. We worked early to develop something called the Alberta Context Tool. I thought I should mention Alberta, which expanded, I keep wanting that to be, expanded the original 4 concepts of leadership, culture, and evaluation to another 7. Organizational slack, are there enough people, time, and space to do the work? Formal interactions, are you involved enough in formal interactions, team rounds and stuff? Informal interactions, how much bedside conversation goes down, in the hall conversation? Resources, do you have the resources necessary to do your work? Things like books, libraries, educators, and social capital, which means to get on with the other people. It's money from the strength of your social interactions. This instrument is now in, the psychometrics are wonderful. It's being used in 14 countries, it's in 7 languages. It's the sort of go-to instrument for measuring context. We also got involved with clinical microsystems. Have you guys all heard about these? If you haven't heard, you should go to the Dartmouth site and read. This is fundamental science for improvement. This says the action occurs at the microsystem. The interesting thing about microsystems is you can't just go and ask, what are your units? At least in nursing homes, it's wrong 25% of the time because they think of units as homes or houses or Eden structures. But these are organizational microsystems. These are places where you manage a group of residents and a group of healthcare providers with consistent management to get the work done. And finally, we have something called the RAI-MDS 2.0 data. It's mandated in Western Canada. It is measured every 3 months on every resident, in every nursing home. A long form is filled out by a nurse, usually. There are some other kind of RAI coordinators. Goes into a machine and spits out quality indicators and adjusted quality indicators. Your fall rate and your fall rate adjusted for the patient population. Your behavior, aspects of the behavior of your patients, both adjusted and unadjusted. Pressure ulcer rates, both adjusted and unadjusted. Use of antipsychotics without a definition, diagnosis of psychosis, adjusted and unadjusted. This is a huge resource that has been really not exploited. We use CI-high standards when we look at this data, but we assign it to the microsystem level and CI-high doesn't. And we can link the RAI data and the data we get from that survey at a microsystem level and a facility level. And what do we know right now? Context. Context is what we've been focusing on because we're thinking about modifiable context because I think that's where you can make the difference. Context matters. If you report only at the facility level, you get rid of huge opportunities for quality improvement. We did a successful pilot project based on this data where we took healthcare aides who are non-registered caregivers who give 90% of the care in nursing homes and are not allowed to speak in many of them because actually they're not nurses, and released them. And using positive deviance produced massive changes in a pilot. And we're out doing an RCT at the moment. And context matters. Better job in vocational satisfaction in frontline staff, better in physical mental health in your frontline staff, less burnout in your front-end staff, better use of best practice by your front-end staff, all depending on better context. Doesn't answer the question, if you change context, do you get better? We're in 2 randomized trials trying that right now. And here's the gold, if you like. Context influences symptom burden in residents. And I'm just going to show you that and then stop. But I have to talk a little bit about measurements. So you got this context thing. It's a 10-dimensional construct. It factors out as 10 dimensions. And you want to show it to Ward's the leader of a nursing home. Ward, here's your context. 10 dimensions. What are you going to tell me, Ward? What am I supposed to do with that? So we had this brilliant, maybe, idea of using something called k-mean cluster analysis on these 10 dimensions. What k-mean clustering does is try to, each nursing home has a point in 10-dimensional space. And can you draw a circle around 2 circles, spheres, 10-dimensional spheres, around the data so that these ones are all lower than these ones. These are the high ones and these are the low ones. And the statistics do that for you. And we called the high ones, the ones with better context, green homes. And they're colored green, cluster 1, and cluster 2, lower context. And I'm just going to show you some data on units, microsystems, and they break about equally in this data. This is data from 2009 to 2012. So we extracted all these RAI assessments. They'll tell me things like, how much pain do you have? And to try to understand it better, what we did was look at patients who died in a nursing home. We want to know what happened at the end of life. Remember, that was one of our things. So we're going to look at when they died. And a lot of patients come into a nursing home for the last 6 weeks of life. Do you think the nursing home should be discounted for that? Like, should you really count that as nursing home care or not? So we said, we're only going to look at those patients that had 4 assessments, had been in for a year. And we're going to look at what happened in the last quarter. And we're going to look at what in green homes happened and what happened in red homes. Is that all clear? A little complex. Picture's not complex. These are people dying. This is the last quarter of life for residents in nursing homes who've been in them for over a year or more. The red homes, starting in 2009, a third of the patients had pain, bad pain, at the end of life, and that didn't change. The green homes started lower, 26%, I guess, 28%, and improved that to 23% by 2012. Those are big changes. I didn't put any stats up. These are all statistically significant. Look at, that's antipsychotics with no diagnosis of psychosis. Is that bad stuff? Well, it is, and I'm not going to go into the reason. This is the pain one. It's even more spectacular. 23 and 25%, not much difference, but by the time we got to 2012, look at the gap. If your mother's in there, which home do you want her in? Which home? You want her in a green home, right? If she's going to die there, wouldn't you rather she didn't have pain? I would. Where do I want to be? There's been a lot of discussion with our decision makers about what's going on here. The sort of consensus at the moment, we haven't proved this, and this data is still this hot off the press, more or less. It needs some more work. There was a lot in the West. This is all Western Canada data. From 2009 to 2012, there were major investments in quality in the nursing home sector. BC assigned quality improvement officers to groups of homes. We, in this province, had a huge change in philosophy with the aging in the community and supportive living. Manitoba redesigned the way they were going to build nursing homes and started working on that. They want to go to smaller, more intimate, home-like homes, and so on. So the theory here is that, or what the decision makers tell us, we haven't proved it yet, is that probably the green homes can pick up on those things and the red homes can't. They're more ready to do improvement. Conclusion, patient safety's arrived. We speak a lot about it, we talk about it, you have courses about it. People aren't hiding from it like they were prior to the adverse event study. We can often successfully improve patient safety practice locally. I showed you that with Safer Healthcare Now. Context seems to be critical for success. That's the Dixon Wood stuff. We don't know much about sustainability and scale up. That's all.
Okay, we've got about 5 or 10 minutes for questions. Thank you, Peter, for
You're welcome.
Lots of great information. So, one of the things that people should see is that now that you've been recruited into the patient safety and quality improvement world, it never ends. You can never leave. So Peter retired 10 years ago, but of course he's not retired. He's still doing amazing stuff and working hard. So, please.
That difference, and so if an individual goes into the ER and they were previously taking testosterone supplements, and then the ER doctor never draws blood and recommends to the family doctor to take them off the testosterone supplements, is that an adverse experience or a medical error, or both?
Well, you can't, nothing is, an adverse event has to have consequence. Remember it said, it was an action that either prolonged hospital stay or caused harm, a long-term disability or worse, death.
Is that towards the patient or
For the patient, for the patient. So just given that much of the story, you can't say if it's an adverse event yet. If, on the other hand, this happens, let me propose that, and for some, the patient's sexual function goes down the tube. He gets better, he goes home, but he can't do something that's very satisfying for him and his partner. Well, we've got an unintended consequence maybe. And Is it a disability? Well, some of us would call that a disability. So it depends on what happens because of it. So when you're trying to find them using the chart review method that the study did, you look, first of all, for things that don't look like they're quite right, and then you look to trace in the chart whether there was a consequence. Like, can you see that the patient actually had to go back? They forgot to put him on his testosterone and his blood pressure tube, and they put him back in the ICU for 5 days. That's bad. Lucky they didn't kill him if they put him in the ICU for 5 days.
Anybody else? Yes.
Can you comment on the carrot versus the stick in how you change these microsystems? And if you were an administrator, you know, with a number of docs under your purview, what's the best way to get docs to change behavior? Because we don't change behavior very well.
Well, that's pretty true about docs. Probably the best thing for you to read is the Dixon Wood stuff that I cited. He looked at that quite carefully. He says a balanced approach. There's nothing wrong with some sticks, but you can't just use sticks, and you can't just use carrots. You've got to not tolerate major, once the team has come together and said we're going to do central lines better, you have to let the team get to that decision. They have to own it. What do you do if one doctor won't follow it? Well, you start with shame and blame, but those are pretty heavy tools. And he would say you have to do a bit of both, and he would say, I don't know the right balance because the context will determine the balance. A strong team of physicians working together, if they agree they're going to do it, and Joe doesn't do it a couple of times, he'll probably come along if he gets his own data. A dysfunctional team where the docs are fighting all the time, and I know more than Ward anyway, so why would I listen to He just talks about snoring all the time. He's asleep. But you know what I'm saying. You have to look at the context.
I do and I don't. I mean, in some ways, I think in the end, we're accountable to patients.
We are.
And so if you know there's an outlier like that, I think as administrators, you're accountable first to the patient and second to the doc. So I guess I wonder about what you think about transparency and accountability to patients and how much, patient advocacy, and they should participate in, sort of how we regulate these initiatives.
I agree. We're just in our TREC program. We've just installed let me back up. We work in what's called Mode 2 research. So Mode 2 research says that the people that are going to use the research have an equal stay in the model, the questions, the dissemination to the researchers. It puts you in a new space for research. Gibbons wrote the original article, Mode 2. If you haven't read about Mode 2 and you're interested in that kind of stuff, you should read Gibbons' work. We are presently integrating residents and persons with dementia and their caregivers in the same way. We've got a group where it's becoming functional. One of the problems is hearing the voice of the residents and not just the voice of their caregivers. A long time ago, I did some work on satisfaction in long-term care, and we clearly showed that the priorities for residents, even with moderate dementia, you can get them, and they're not the same as the families. There's two customers for the care. That's all that's saying. I'm not saying the family's wrong, but this has been a big struggle for us, and we're getting some pushback from both decision makers and researchers about, well, you can't listen to them. They're demented and old. Well, give me a break, really. Of course we're going to listen to them, and they'll probably make our research better or our administration better. So in the long-term care sector, you would not have a progressive nursing home unless you had a very active family council and resident council who came and talked to you as the CEO. And they would say, that doctor is not coming when he's asked. And then you'd have to decide how you're going to deal with it. So I agree with you. I agree. But I think it's important not to have it under the rug in any way, and that's what we've tended to do with it, with the docs especially.
So I'm going to make a suggestion.